Infertility. Infertility is defined as the failure of pregnancy after 2 years of unprotected, regular, that is 2 times per week sexual intercourse, and it affects around 10% of the all couples. Couples who fail to conceive after 1 year of regular, unprotected sexual intercourse should be investigated. Um, Male factors are responsible for up to 25%, and out of that, most of the causes are 60% of the male factors are idiopathic in nature. So the causes of male fertility include primary gonadal failure, secondary gonadal failure, genital tract abnormalities, erectile dysfunction, drugs, and systemic disease. Among the primary gonadal failure, genetics is one of the most important factor, and among the most common conditions, Klinefelter syndrome, Y chromosome microdeletions, immotile cilia cartilaginous syndrome, and cystic fibrosis are the common genetic conditions. Furthermore, congenital cryptorchidism, orchitis, torsion or trauma, chemotherapy or radiotherapy, alcohol, anabolic steroids, varicocele, and idiopathic are the causes leading to primary gonadal failure. In the secondary gonadal failure, hypogonadotropic hypogonadism and structural hypothalamic pituitary disease are the other causes. Obstructive congenital, infective or post-surgical, and sperm autoimmunity are the common conditions uh, associated with genital tract abnormalities. Then drugs including the spironolactone, corticosteroids, and sulfasalazine are the offending drugs. Among the systemic disease, cystic fibrosis, Crohn's disease, and other chronic debilitating conditions are associated with infertility. So the evaluation of the male infertility should be done. Among the male factors, history and physical examination should be done initially. Symptoms of androgen deficiency include a reduced libido and potency, a reduced frequency of shaving, and sometimes it may be asymptomatic. Drug history is very important. Drug or alcohol use and the use of anabolic steroids may all contribute to hypogonadism. Other drugs that may affect spermatogenesis include sulfasalazine and methotrexate. Cytotoxic chemotherapy may cause primary testicular failure. History of infections, particularly mumps, orchitis, sexually transmitted disease, or epididymitis are the other contributing factors. Then bronchiectasis may be associated with epididymal obstruction with severe asthenospermia. Testicular injury or surgery may cause disordered spermatogenesis. Secondary sexual characters may be absent in congenital hypogonadism. Anosmia is present in Kallmann syndrome, and gynecomastia may suggest hypogonadism. Testicular size should be measured. Normally, it is between 15 to 25 ml, which is reduced to less than 15 ml in hypogonadism. In Klinefelter syndrome, it is often less than 5 ml. In patients with a normal testicular size, suspect genital tract obstruction, like the congenital absence of the vas deferens. Examine rest of the external genitalia, look for the penile urethral abnormalities and epididymal thickening. So first of all, it is very important to get the semen analysis in the diagnostic workup of infertile couple. If it is normal, then male cause is excluded. If abnormal, then repeat the semen analysis approximately 6 to 12 weeks later. Semen collection should be performed after 3 days of sexual abstinence. If a zoospermia is present, then rule of obstruction if SH and testosterone concentrations are normal. Asthenospermia or immotile sperm is usually due to immunological infertility or infection of the prostate. High semen viscosity, pH, and leukocytospermia can also be present. So first of all, semen analysis done. If it is normal, then investigate the female partner. However, if the semen analysis is abnormal, then we should get the FSH and testosterone. If FSH is increased, then it is primary gonadal failure. In that case, karyotyping should be done. However, if the FSH is normal, then we should exclude the obstructive lesions, immunological causes, and infections. If FSH is low, most likely it is hypogonadotropic hypogonadism. In that case, prolactin prolactin levels should be measured, and as well as the pituitary MRI should be done. The semen analysis, according to the WHO criteria, is the volume should be greater than 2 ml, the pH should be greater than 7.2, and the total sperm number should be greater than 40 million per ejaculate, and the sperm concentration should be greater than 48 million per ml, and more than 60% should have a progressive motility, more than 12% should have a normal forms, and live sperms should be greater than 75%, and leukocytes should be less than 1. So LH and LH, FSH, testosterone, and SMBG levels are also measured. FSH may be elevated in the presence of normal LH and testosterone levels and oligospermia. This may be seen in male who are normally virilized but infertile as a result of disordered spermatogenesis. So then low FSH, LH, and testosterone concentration suggest secondary hypogonadism. An MRI of the pituitary gland and hypothalamus is necessary to exclude the organic cause. Urine bacteriology should be performed in patient with leukocytospermia. Scrotal ultrasound may help in the diagnosis of chronic epididymitis. Male being investigated for infertility are at increased risk of testicular tumors. Karyotyping may be helpful in male with the primary testicular failure. Klinefelter syndrome is a cause of infertility, and deletions on the long arm of the Y chromosome has been found in a significant proportion of the azoospermic male. Sperm antibodies in semen should not be measured routinely, as specific treatment is rarely effective. Testicular biopsy is ready diagnostic, but may be used to retrieve the sperm. So now the management of the male fertility. If it is hypogonadotrophic hypogonadism, then gonadotrophins are given. It is in the form of HCG, which is given 1500 to 200 international unit IM twice per week. Most also require FSH, HMG 150 international units 3 times a week. Monitor serum testosterone and testicular size. And main side effect is gynecomastia. Or the other option is pulsatile GnRH, which is generally not used in men. Once the testes are greater than 8 ml, semen analysis should be done every 3 to 6 months. It takes around 2 years to maximize the spermatogenesis. Normalization of the spermatogenesis in 80 to 90% of the male. Once spermatogenesis is induced, it may be maintained by the HCG alone. In idiopathic semen abnormalities, there is no evidence to suggest the use of androgens, gonadotrophins, or antiestrogens to improve fertility in male with idiopathic disorder of spermatogenesis. In obstructive azoospermia, reversal of vasectomy may result in successful pregnancy in up to 50% of the cases within 2 years. Microsurgery is possible for most other causes with successful pregnancies in 25% of the couples within 18 months of treatment. In case of unexplained infertility, so it is defined as infertility despite normal sexual intercourse occurring at least twice weekly, normal semen analysis, documentation of ovulation in several cycles, and normal pattern tubes. 30 to 50% will become pregnant within 3 years of expected management. If not pregnant by then, chances that spontaneous pregnancy will occur is greatly reduced. NIRT should be considered. If the female is more than 34 years of age, then expectant management is not an option, and 6 cycles of the IUI or IUF should be considered. It may result in super ovulation with IUI can achieve a pregnancy rate of 15% per cycle, and cumulative delivery rate after several cycles of 50%. IVF offers a live birth rate of greater than 30% in younger female and a cumulative delivery rate approaching 80%. ICSI allows IVF to be offered in severe oligospermia with pregnancy rates equivalent to a standard IVF. Slight increase in congenital malformation after ICSI has been observed. The significant risk of multiple pregnancies with any form of ART has been documented. So ovulation induction.